Hi everyone, my name is Ellie Hobday and I'm a licensed LPN and RN student. Today I'll be presenting my proposal on improving pain recognitions in nonverbal adults with intellectual disabilities. This project focuses on a major gap in care that I've seen firsthand as a caregiver. I have been a caregiver to a nonverbal and intellectually disabled young adult with Angelman syndrome for 5 years now, and can confidently say that nonverbal individuals often experience pain that goes unrecognized, which can lead to serious health consequences. I'm going to start by going into the details about our agenda. First, we're going to start with our needs/problem. The main thing is that pain goes unrecognized in nonverbal individuals with intellectual disabilities. Then we're going to go into why it matters, and then the main consequences and reasons for that problem. After that, I'm going to explain my proposal solution, how it works, and how it would be implemented in real care settings. Then I'll briefly go over the budget and finish with a conclusion and recommendation. The main problem is that pain is often not recognized in nonverbal adults with intellectual disabilities. Because these individuals can't verbally communicate discomfort, pain shows up as behavioral changes like agitation or withdrawal. The issue is that these behaviors are often misunderstood or missed completely, which leads to missed assessments, delayed treatment, and worsening medical conditions. The need that was identified through my research is that there is a need for better early recognition of pain in this population. The first major issue I'm going to talk about is communication barriers. Nonverbal adults with intellectual disabilities often can't directly report pain. So instead, it shows up through behavioral changes like agitation, withdrawal, or changes in energy level. The problem is that without a structured way to assess those behaviors, caregivers are left interpreting them based on their own experience or familiarity with the individual. That can work well if someone knows the patient really well, but in reality, especially in group homes or residential settings, staffing changes frequently, so newer staff or float staff may not recognize subtle changes from baseline. Because of that, pain can be easily missed or misinterpreted. Research supports this. Studies show that pain in this population is often under-recognized because assessment is inconsistent and not standardized. So overall, communication barriers create a situation where pain is present but not clearly identified or documented. The second major issue is diagnostic overshadowing. This happens when a person's behaviors are assumed to be part of their intellectual disability rather than being recognized as a potential medical problem. For example, if a patient becomes more agitated or withdrawn, it might be attributed to their baseline behavior instead of being investigated as a possible sign of pain or illness. This is especially risky in nonverbal individuals because they can't clarify what they're feeling or advocate for themselves. As a result, medical concerns may not be addressed in a timely way, which can lead to delays in diagnosis and treatment. Research shows that adults with intellectual disabilities have significantly higher rates of death from treatable causes, which suggests that these delays are not isolated incidents, but part of a larger systemic issue. So diagnostic overshadowing contributes directly to missed opportunities for early intervention. The third issue is the impact on overall health outcomes and how it's normally worse. When pain is not recognized, it often means that an underlying medical issue is also going untreated. This could be something like an infection or an injury or a worsening chronic condition. Without early intervention, these conditions can progress and become more serious, leading to complications that could have been prevented. This is especially important in this population because individuals with intellectual disabilities often have more complex medical needs. Research shows that about 58% of deaths in this population are considered potentially avoidable, according to Thygesen et al. That statistic really shows how significant this issue is. When pain is missed, it's not just about discomfort. It can have serious consequences for overall health and survival. My proposed solution is to implement a standardized behavioral pain assessment protocol using the Nonverbal Pain Scale, or NVPS. This would be introduced into both home-based care and group living settings, since those are the environments where nonverbal adults with intellectual disabilities most commonly receive care. The plan is to integrate the NVPS into daily caregiving routines, rather than adding something completely separate. Caregivers would complete an assessment at least once per shift and anytime there is noticeable behavioral changes. Implementation would begin with structured training sessions led by a registered nurse or clinical educator. These sessions would focus on how to recognize behavioral indicators of pain and how to properly score the NVPS, and how to document and communicate findings. After training, there would be a short pilot phase where the tool is used in practice with support from the RN or project lead. During this time, caregivers would receive feedback and reinforcement to ensure that the tool is being used correctly and consistently. I've added this slide to show what the actual assessment tool looks like in practice. This is the nonverbal pain scale that I have made, that I've adapted from Odner et al. From 2003. The NVPS evaluates 5 different categories: facial expression, activity and movement, guarding, vital signs, and respiratory status. Each category is scored from 0 to 2. 0 would be a negative sign for pain, 1 would be a minor sign for pain, and 2 would be a major sign for pain. After that, the scores are all added together to create a total score from 0 to 10. A score of 0 means that no pain is noted. A score of 2 to 4 is mild pain. 5 to 7 would be moderate pain, and 8 and up is intense pain. This scale gives caregivers a structured and objective way to assess pain, instead of relying on interpretation of behaviors. Using this pain scale for nonverbal, intellectually disabled patients will lead to greater recognition of pain, and it is a consistent and easy to teach scale. After understanding what the nonverbal pain scale looks like, this is how it will work in practice. First, the caregiver will observe the patient's behavior. It may be on a scheduled time, maybe once per hour, once per day, once per shift, or it might be because you notice the behavior. First, they're going to look at it, and then they're going to assign a total score from 0 to 10, depending on that nonverbal pain scale that we were just looking at. That score is then documented and then communicated to the nurse, provider, parent, or whoever is in charge of managing pain. This creates a clear and consistent way to recognize and report pain instead of relying on vague descriptions. How using the nonverbal pain scale solves the problem. This is where the solution directly connects back to the problem I talked about at the beginning. Right now, pain recognition is inconsistent and depends heavily on the caregiver's experience or familiarity with the individual. That creates a lot of variability and room for error. By introducing the nonverbal pain scale, we're replacing that subjectivity with a standardized process. Every caregiver is going to be using the same criteria and scoring system, which will improve consistency across shifts and staff members. It will also improve communication. Instead of vague statements like, "they seem uncomfortable," caregivers can report a specific score and observed behaviors. That makes it much easier for nurses, providers, and whoever is taking care of the patient to understand what's going on and respond appropriately. Another important piece is caregiver confidence, especially in settings with high staff turnover or less experienced caregivers. Having a structured tool will help them feel more confident in recognizing and reporting pain. Overall, this will lead to earlier recognition, faster intervention, and better outcomes for patients. This is our budget. I've included the budget graph that I've included in the report. The total cost of the project will be approximately $5,131. The majority of this cost comes from staff training and implementation support, not equipment. I feel like this is important because it shows that the project is focused on improving practice, not just adding resources. We've also included RN or clinical educator time to develop and deliver the training, as well as project coordination to make sure everything runs smoothly. The tablets are included to support documentation and tracking, but they're not absolutely necessary. This system could still work with paper documentation if the iPads are out of the range of your budget. Overall, I believe that this is a relatively low-cost intervention, especially when you consider the potential costs of misdiagnoses, hospitalizations, or worsening medical condition. So from a cost-benefit perspective, I believe that this is a small investment with a potential for a significant impact on patient safety and quality of care. To summarize, the main issue is that pain is often underrecognized in nonverbal adults with intellectual disabilities, which can lead to preventable harm. This proposal offers a practical and realistic solution through the use of a standardized assessment tool. The Nonverbal Pain Scale, NVPS, provides structure, improves the communication, and supports more timely and appropriate interventions. One of the strengths of this project is that it can be applied across multiple care settings, including both home-based care and group living environments. That makes it scalable and adaptable, depending on the population and resources available. It's also a cost-effective program and builds on existing staff roles, which makes implementation more feasible across more groups. Overall, I believe that this project addresses a real gap in care and has the potential to significantly improve outcomes for a vulnerable population, those who are nonverbal with intellectual disabilities. For those reasons, I strongly recommend the approval of this proposal. That's all I have for this presentation. Thank you all for your time. I'd be happy to answer any questions that any of you guys may have, and please send me an email or let me know if you have any other questions. Thank you.